Daiichi Sankyo.
Good evening, everyone. Welcome to the webinar today. And also Happy New Year, everyone. So today we are going to talk about Destiny Breast 03. The next page, yes. First, I would like to introduce myself. My name is Shen Lu. I'm a professor of biostatistics and bioinformatics in Duke University. I will be the host today. Yeah, next, I would like to briefly introduce the agenda for today. So we are going to have a keynote speech by Dr. Sarah Hurwitz from UCLA. And after that, I will give a brief comment about the presentation. And I will share about some details in the studies. And next, we will have a panel discussion. We have an excellent panel today. Can I have the next slide, please? Yeah, this is more for the audience. If you are using Zoom, please note that there is a Q&A window. You can click on that Q&A. You can type your question there. So for those of you who want to listen to the Chinese language interpretation, you can choose the language interpretation. And because we are going to use English, so there's no English translation this time. And next, we are going to introduce our first keynote speaker, Dr. Sarah Hurwitz. She is the professor of medicine in University of California, Los Angeles. Let's welcome Dr. Hurwitz.
Thank you so much. It's my pleasure to be here, and I'm going to share my slides now. And what I will be doing right now is presenting the data from the Destiny Breast 03 clinical trial. These are the data that we presented at the San Antonio Breast Cancer Symposium just over a month ago. Here are my declarations of interest. The Destiny Breast 03 trial is the first phase 3 comparative trial of T-DXd to report out. In this trial, patients with HER2-positive advanced breast cancer previously treated with trastuzumab and a taxane were randomly assigned 1-to-1 to either Q3 weekly TDM1 or Q3 weekly TDXd at the doses shown there. The primary endpoint was progression-free survival by blinded independent central review, and the interim analysis of these data were already presented at ESMO by my colleague Javier Cortez, which showed a significant improvement in the progression-free survival with a hazard ratio of 0.28 at the interim analysis. We presented at San Antonio the subgroup analyses from this clinical trial. Patients were stratified by hormone receptor status, prior treatment with pertuzumab, and presence of visceral disease. Note that brain metastases was not a stratification factor. Patients who had asymptomatic brain metastases that did not require steroids or anticonvulsants were allowed on this clinical trial if they had recovered from the acute toxic effects of radiation therapy. A minimum of 2 weeks had to have elapsed between the end of whole brain radiation and study enrollment. Prior to a protocol amendment, patients with stable, untreated brain metastases were eligible for this study, but a very small fraction of patients enrolled that had untreated brain metastases. Those who had a history of brain metastases were required to have imaging of the brain at baseline, and lesions were monitored throughout the study. Here are the baseline characteristics of patients as well as their prior therapies. The demographics shown here were well balanced across the treatment arms. Patients were predominantly from Asian countries, with 57% and 61% of patients from an Asian region for TDXD and TDM1 respectively. And this is due to a greater patients per site in Asia. The site selection was actually fairly evenly distributed between Asia, the European Union, and Americas. Over 20% of patients had any recorded history of brain metastases in each arm, and approximately 15% of patients had clinically stable brain metastases that were observed in the baseline scan. And it's this population of patients, those with brain metastases at baseline, that we'll be looking at in the subsequent slides that I'll be showing you. Approximately 60% of patients in each arm had previously been treated with pertuzumab. Sorry, let me just... All right, so here is the progression-free survival by blinded independent central review at the interim analysis, which was presented at ESMO. As you can see, the median progression-free survival with TDXD had not been reached yet and was 6.8 months for TDM1. The hazard ratio was 0.28 with a highly significant p-value of 7.8 times 10 to the negative 22nd. In this arm. The median follow-up, or in this trial, the median follow-up for PFS was about 15 and a half months for TDXD versus 13.9 months for TDM1. 32% of patients treated with TDXD had progressive disease versus 59% of patients treated with TDM1. Here are PFS in key subgroups, and as you can see, TDXD demonstrated benefit across key demographic and prognostic subgroups with consistent hazard ratios based on hormone receptor status, prior use of pertuzumab, presence or absence of visceral metastases, number of prior lines of therapy, as well as presence or absence of brain metastases at baseline. In addition, there were consistent objective responses noted in TDXD across the different demographic and prognostic subgroups. And as you can see, the objective response rate for all patients was almost 80% for TDXD, 34% for TDM1. TDXD is in the blue bar and TDM1 in the gray bar. And regardless of whether you base it on hormone receptor status, prior pertuzumab treatment, visceral disease, prior lines of therapy, or presence or absence of brain metastases, TDXD is associated with a higher objective response rate than TDM1 in each of these subgroups. Now shown here are the Kaplan-Meier curves for progression-free survival based on whether patients had brain metastases at baseline or not. Those on the left, the Kaplan-Meier curves on the left, are for those patients with brain mets at baseline, and you can see the median PFS was 15 months with TDXD versus 3 months with TDM1. And on the right side, those without brain metastases in general did better. TDXD did not yet reach a median PFS, whereas TDM1 was 7.1 months. Now looking at the confirmed objective response rate and best overall response for TDXD versus TDM1 based on whether or not patients had brain metastases or not, you can see in the blue columns TDXD, in the gray columns TDM1. For patients who had brain metastases, 67% achieved an objective response rate overall versus 20.5% of patients treated with TDM1 who had brain metastases achieved an objective response rate. The median duration of response for patients with brain metastases at baseline treated with TDXD was almost 13 months versus 7.2 months with TDM1. Now, these are the data that I think struck many of us a lot, and that is the intracranial objective response rate seen in the patients who had baseline brain metastases. Focusing on the table on the right, this includes patients who had baseline brain metastases per investigator and had resist intracranial lesions that were measurable at baseline by blinded independent central review. This table includes those with target and non-target lesions in the brain and comprises a total of 72 patients, 36 in each arm. Those treated with TDXD, roughly 63% had an intracranial objective response, compared to about 33% for those treated with TDM1. This included a complete intracranial response by blinded review of 28% for TDXD versus 3% for TDM1. 2.8% of patients treated with TDXD experienced intracranial progressive disease versus 22% of patients treated with TDM1. The waterfall plot on the left is only including the 44 patients who had target lesions by blinded independent central review using RECIST criteria, and you can see a greater response with TDXD in the brain compared to TDM1. Now, we are showing here the overall and exposure-adjusted safety summary. Let's keep in mind that the median duration of treatment was 14.3 months for TDXD and 6.9 months for TDM1. Exposure-adjusted incidence rates, or EAIRs, are a standardized measure of risk per patient year that is commonly used to summarize safety data in long-term studies with potential differences in the follow-up duration between treatment group. The exposure-adjusted incidence per patient year is presented to account for this difference in duration of treatment among the treatment arms, with TDXD treated patients being treated for a longer period of time due to their prolonged progression-free survival. Although rates of any TEAEs and TEAEs of grade 3 or greater were generally similar between arms, the exposure-adjusted rates were lower with TDXD versus TDM1. And although rates of TEAEs associated with discontinuation were greater with TDXD versus TDM1, when you take into account exposure-adjusted rates, they were generally similar. The most common TEAEs of any grade in at least 20% of patients in each arm are shown here, and you can see that any grade nausea occurred in about 76% of patients with TDXD versus 30% with TDM1. Vomiting occurred in 49% of TDXD and 10% of TDM1, respectively. And fatigue, about 49% treated with TDXD versus 35% treated with TDM1. The most common grade 3-4 TEAEs in at least 20% of patients treated with TDXD were hematologic and included neutropenia in 19% of patients, thrombocytopenia in 7% of patients, compared to 3.1% and 24.9%, respectively, of those treated with TDM1. So TDM1 has a greater incidence of thrombocytopenia, whereas TDXD has a greater incidence of neutropenia. Interstitial lung disease is a very important adverse event associated with TDXD. We know from the DESTINY-Breast01 clinical trial that almost 3% of patients died from ILD. And so this was a AE of special interest in this particular clinical trial. Fortunately, we observed no deaths from ILD and no grade 4 events of ILD in this clinical trial. And in fact, the overall rate of ILD was 10.5%. With only two patients who had grade 3 ILD. We decided to look at the rates of ILD comparing the Asia subgroup versus non-Asia subgroup because previous analyses had suggested that Asian patients may have a greater risk of ILD. And actually, based on our analysis, the rates were quite similar comparing Asia and non-Asia subgroups. And so we don't see that Asian subgroups were developing ILD at a higher rate. So in conclusion, in this exploratory analysis of the phase 3 DESTINY-Breast03 trial, TDXD did demonstrate consistent efficacy benefit in terms of progression-free survival and objective response rates over TDM1 across various patient subgroups. In patients with and without brain metastases, TDXD demonstrated greater efficacy compared to TDM1. Moreover, somewhat surprisingly, TDXD also demonstrated a marked benefit in the intracranial objective response rate in those who had baseline brain metastases and a reduction in CNS disease. Moreover, the safety profile with TDXD appears manageable. There were no new safety signals, and the ILD rate is lower than reported in the single-arm DESTINY-Breast01 trial. These data do support TDXD becoming the standard of care where it's available in countries where it is available as the second-line treatment after trastuzumab and taxane. And so here are some acknowledgement, of course, for the patients and their families, as well as the study site staff and the sponsors shown here. Thank you very much.
Thank you, Dr. Hurwitz. Next, I'm going to give some comment about the study details, especially the study design. Let me share my slides. Okay, so as we know, the TDXD received the breakthrough therapy designation. This will happen late last year. So this was based on the DESTINY-Breast03 clinical trial presented in ESMO, as Dr. Hurwitz mentioned. This is one of the results of the primary endpoint, PFS by blinded independent central review. So we can see that the p-value is extremely small, 7.8 times the 10 to negative 20 second. And also another result is the secondary endpoint is the PFS by the investigator assessment. So we can also see that the HR is the 0.26 with the p-value very similar to what we had before. We have a very consistent result. So this is a very encouraging positive result. So I think we received some questions from the audience. I would like to take a few minutes to explain what that means. So first of all, so we rarely see the very small p-value. So one question is what does this extremely small p-value means? I think what that means is that if the treatment was not efficacious, it will be very unlikely it will be having this kind of chance to observe this strong positive result. In other words, since we observe the strong positive results, it's very unlikely that the non-hypothesis, which is the treatment is not efficacious, is true. So in other words, we can say with very strong confidence that the treatment is efficacious. So in general, the smaller the p-value is, the stronger our confidence should be, right? So another question is what's the difference between the PFS by BICR, blinded independent central review, versus the PFS by investigator? So which one is more objective? So I think the difference is that the PFS by investigator is that the progression was evaluated by investigator, while in the PFS by BICR, the progression was evaluated by a blinded independent review panel, so that that panel was blinded to the treatment allocation, so they did not know which patient received which treatment. But from this definition, you can see that this the BICR PFS, the definition is the much more objective as compared to the investigator. Now, today I'm going to highlight some of the study issues from this Destiny Breast 03. So I'll talk about the study design from study endpoint selection point of view, and also control of type and error, sample size, stratification, and line of treatment and control arm. And also I'll talk about a little bit of a management of AE versus the proper patient selection. And I will briefly go through the early phase data. So I borrowed this slide from Dr. Hurwitz. One thing I want to mention is that so we have a PFS, the progression-free survival, as the primary endpoint, or we can say as the only primary endpoint. Now, we do have the overall survival as the key secondary endpoint. So this is what we call a gatekeeping strategy, so that you will test the PFS the first with the alpha of equal to 0.025. It's the 0.025 because it's the one-sided test. If the PFS is significant, you can pass this alpha to the key secondary endpoint, OS, with the same alpha level. Now, let me briefly talk about what that gatekeeping strategy means. So this is the guideline from FDA guideline from this multiple endpoint clinical trial guideline. So they have a specific section about gatekeeping testing strategy. So I sum up the key point here is that so first you test the primary endpoint. In the previous case, so the primary endpoint is the PFS. You test the hypothesis of PFS first, and if you do get the significant result, and then you go ahead to test the secondary endpoint. So by passing the unused alpha to the secondary endpoint hypothesis testing. Now, in contrast, I want to talk a little bit about this Emilia study for TDM1. Now, in contrast, they use the so-called fixed sequence design. So I think the difference here is that they have two primary endpoints instead of one. So they have PFS and OS as the primary endpoint. So they use the so-called fixed sequence. So the name is a little bit different, but the idea is identical. So you do the hypothesis testing for PFS first, and then if you get significant, you pass the alpha down to OS with the same alpha level. So in that case, on the other hand, if the PFS is not significant, you will not be able to do the hypothesis testing for OS. This is the downside of the either the fixed sequence or the gatekeeping. So now here we can see that some sample size calculation details from this Breast 03 study. So they used 90% power for HR equal to 0.7 for the one-sided test with alpha equal to 0.025 when selecting PFS as the primary endpoint. So Now, there are some interesting questions that I also received from the audience. So the first one is about endpoint selection. Why OS is not a primary endpoint in breast-03? I think there are two reasons. I think the panelists can correct me if I'm wrong. So I think one reason is that there must be some communication with the FDA or other regulatory agency, so that they allow the PFS being used as the primary endpoint, and the OS is used as the key secondary endpoint. I think another reason is that so if you get a PFS the significance, so it's likely that you have you can get the result first, right? You can get PFS first, and then if you get a significant result while you're waiting for the result for OS, it's likely that the FDA may grant you the approval because you already received a positive result from PFS. So now, what's the design difference between breast-03 and Emilia? I think one key difference is the OS was the one of the primary endpoint in Emilia, but it was the key secondary endpoint in the breast-03. The advantage of gatekeeping is that because you use all the alpha and then to calculate the sample size. So in general, when you use gatekeeping or fixed sequence, the sample size tend to be smaller as compared to using the Bonferroni method. Because when you use the Bonferroni method, you have to divide the alpha in some way, right? So that will, in general, increase your sample size. Okay, so another question is that in the breast-03 studies, is OS considered when calculating the sample size? My guess is yes, because I think is the OS was the key secondary endpoint. So the sample size calculation must consider OS. Now, next, I want to talk a little bit about the stratification factors. From the protocol, we know that they have selected the three factors as the stratification factors: the hormone receptor status and prior treatment with pertuzumab, and also the history of visceral disease. Now, I want to also get these questions from the audience. So now, first question is why not use the brain metastasis as the one stratification factors? Now, what's the disadvantage of using BM as the stratification in addition to the three factors, right? And also, what if the BM is used as the stratification factor? What will be the result? Now, first, I want to spend a couple minutes talk about what is the stratification randomization. So the definition from FDA guideline is that we randomize the individual within each strata, depending on their baseline characteristics. So within each strata, we randomize the people equally to treatment versus the control. Now, the purpose is that so we want to achieve balance between arms with respect to the known prognosis factors, such as the say region, center, disease stage, gender, and so on. And the main purpose is to control for some confounding factors. So there are some principle here. We got this from the good review practice from FDA. So I think one principle is that the stratification factors must be those that are potentially correlated with the treatment effect, okay, such as disease stage or PD-L1 status, and so on. So usually when we select the stratification factor, we have to consider whether or not they are correlated with the treatment effect. Now, and another principle is that it's necessary when the magnitude of the treatment effect vary among important groups. Okay, so in that case, the stratification analysis is more likely to detect a treatment effect. Okay. Also, I posted the guideline here. Now, with these two guidelines, let's go back and see whether or not we should use the brain metastasis as the stratification factors. So let's look at the results. Now, first thing I want to point out is that if you look at this sample size, so there's the pretty good balance between the treatment versus the control group, right? And same thing with the no brain metastasis group. There's a very good balance here. Now, if you look at the sample size, the brain metastasis account for about 15% of the total sample. And next, we look at the results. So if you compare this, the median PFS from the TDSD in the brain metastasis group versus no brain metastasis group, you can see that certainly in the BM group, the treatment effect, PFS does tend to be smaller, right? So here the median PFS is the 15, and here we don't know, but at least it's larger than 22.2 months, right? So because that's the lower bound. So and then we can see that also the 12-month PFS rate in the brain metastasis group, it tend to be a little bit smaller. So it seems that the second principle, as we mentioned before, was satisfied, right? And also we know that the BM has to do with the effect size. So it seems that the two principles both were satisfied here. So in my opinion, BM could be used as the stratification factors, right? Now, but if it was used as the stratification factor, would that change the result? My guess is no, not much. The main reason is that because here we already achieved pretty good balance in terms of the treatment allocation in both the BM versus no BM group. So even if you use the stratified analysis, it may not change the result much. Okay. And also this to show the result of BM in BM group versus no BM group. You can also see that you tend to have worse ORR in the BM group as compared to the no BM group. Okay. Yeah, and another thing I want to mention is about AE. Is the ILL lung disease. So we can see that this is the phase 2 paper published in New England before. Now we can see that the result here show that we have a 2.2% grade 5 ILD here from the breast 01 study. Now, in contrast, as Dr. Hurwitz presented today, so we in breast 03 we do not have any grade 5 or any grade 4. So it seems that no grade 4 and no grade 5, right, in the breast 03. So it seems that the AE was well controlled. Why is that? Why did that happen? I think one reason is that we look at the exclusion criteria of a breast 03, right? They have among many exclusion criteria, specifically there's one has to do with the ILD. So here they exclude the people with a history of ILD. And also if they have a current ILD, they will exclude it. And also if they were suspected to have ILD, they will exclude it. I think one of the reasons that they have a very good control of ILD in SAE. Now, also, I borrowed this slide from the breast 09. I think in breast 09, they also have the similar exclusion criteria. Okay, so that's why we believe that this could be one of the reasons. Okay, now also I want to spend the next few minutes talk about the breast 03 early study data. So here is the phase 1 study result published in Lancet Oncology in 2019. So basically here, one thing I want to say is that this result was based on the data as of August 10 of 2018. Okay, they presented the results. Now, as we know, one of the main purpose of this study was to identify the optimum dose, right? So here they compare the two candidate doses, the 5.4 milligram per kilogram of body weight versus 6.4 milligram. So if you look at the ORR, you can see that in 5.4, you have a 56.5% versus the 61.5% in 6.4 milligram. So very similar with the 6.5 milligram, slightly better in ORR. Now, if you look at the PFS, the result comparing these the two dose group, seems that the median OS for 5.4 group is the 22.1 month versus the 13.9. So 5.4 milligram group tend to be slightly better, but it's hard to say this way because the sample size is relatively small. So we can still say that they are relatively close. However, in the paper, they concluded that the proportion of patients who had the complication, which is the ILD, was lower for those who received 5.4 as compared to those who received 6.4. Looks like if you use 5.4, you tend to have a lower chance to have ILD. So I think that's the one of the main reasons they chose the 5.4 milligram as the final dose. Here also we can see that in the 5.4 milligram dose, that you tend to have fewer AE as compared to 6.4 milligram. Okay? Now, another interesting thing here is that they also, after the phase 1 study, they also run a phase 2 study, BREST-01. So in this study, they also look at the different doses, right? In addition to this 5.4 and 6.4 milligram dose, they also look at the 7.4 milligram dose. And then they have two phases, 2 stages with the 60 plus 60, so 120 additional individual to identify the optimum dose. So I think the 2 questions the audience asked is why search for a dose again in phase 2 while you already got a pretty good dose in phase 1, right? Or how many patients required to find optimum dose? We know that in the gastric cancer case, also of the same medication, right? So they only require 44 in phase 1 to find the optimum dose. Why is that in this the trial we need that many people to find the optimum dose, right? So we can discuss those questions later on. So I think one reason I think I want to highlight is that here, the BREST-03 has the faster enrollment and the faster publication within about 3 months. So I think the one reason to answer that question is that the cutoff date for the BREST-01 is for the data analysis is the August 1st of 2019. So I think, So now, if you compare the results under different doses, you can see that the message here is that you tend to have a better ORR in the higher doses as compared to the lower dose, such as the 5.4. But the result is still relatively close. However, as we mentioned before, the lower dose, 5.4 milligram, tend to have a fewer AE. Okay. So now to sum up this result from phase 1, I think the strategy, very important strategy, is that they target the later line with the patient with at least 3 lines of treatment. Now the median of is the 7 line, 7 previous treatment with the range of 5 to 11. Now, they also, in phase 1, they also received the breakthrough designation with a lot of advantage for their future studies. Okay, I think we have a class dedicated for this, introducing all the designations from FDA, including the breakthrough. Okay, so just to point out one interesting fact about breakthrough is that you can begin to apply for the breakthrough designation as early as the phase 1, as from the FDA guideline. Also, I want to sum up the good results they got from phase 2. So this is the paper published in New England Journals 2020. So some key point is that this is the phase 2 study is the single group or single arm studies. Now with the median of 6 the previous treatment received. And we can see that the result here is that based on 112 patients, they have a ORR of about 61% and PFS of 16.4 months. And with this good result on December 20 of 2019, they received accelerated approval from FDA. Now, I think the strategy for success in here is that, especially the strategy in phase 2, is that they target third line and later line after the TDM1 treatment. I think this is the unmet medical need. Also, they use the single arm study here because they target the later line of a treatment. So from this, the two strategy. Because of the positive result, they received accelerated approval based on that study. So, and later on in the BREST-03, which is the phase 3 study, they target the second line patient, and also in the ongoing BREST-09 study, which is also phase 3, they target the first line of treatment. Okay. Both of them target for regular approval. Another thing I want to mention is that it's quite interesting that if you look at the result from 2012 Emilia studies, you can see they already get the ORR of about 44% with the PFS of 9.6 months, right? So, but if you look at the TDSD early phase result in phase 1, you can see that the ORR is about 58%, right? And then in the dose expansion phase, they also have a consistent result about 60% in ORR, right? And then the PFS is 22.1 months. So if you compare this good result with the second line treatment reported in the Emilia, right? So it looks like they can directly target second line in the study, right? So, but instead, they conducted a phase 2 studies targeting third line treatment. So they tend to be very conservative. I think this is one of the interesting points I want to make. When they designed the study, they did not directly go to the second line without going to the third line, targeting the third line treatment. So I want to summarize the results from the Destiny breast studies, including all the early study. So in the first phase, that they received the breakthrough designation and targeting later line. Right? In the phase 2 studies, that they target a third line or later, and in BREST-01, they received accelerated approval. And then in the BREST-02, they target treatment regular approval from phase 3. Targeting third line, and then in BREST-03 they target second line, and then in BREST-09 they target the first line. In our opinion, the key to the BREST-03 success is that they have excellent early phase data. They have used a lot of patients, more than 200 patients, to identify the optimum dose, and they use the endpoint selection using PFS as the only endpoint, and using the gatekeeping strategy. So that way they can save the sample size because they don't have to allocate or split the alpha. And they also have a very good power. In their power calculation, they used 90% for PFS, which is their only primary endpoint. And they have a good management of AEs used with proper patient selection, mainly excluding people with the history for ILD. Also, they have a good strategy starting from late line of treatment first, and then they slowly move on to the second line and then the first line of treatment. Okay. Now, one last thing I want to say is that what will be the OS results in the breast-03? Even though the results may not be available yet, we want to kind of mix a little bit of prediction. Hopefully our prediction is correct. So here I presented the result from say the Emilia and the breast-03 results, and also the Destiny breast-03 second line results, right? And also the breast-01 third line or the later line results. So so we can look at all these results. My guess is that the result will be way better than this, right? So maybe Dr. Purvis can correct me if I'm wrong. So I think it will be result will be better than all these results presented here. I think in comparison, we want to briefly look at one unsuccessful example is the Beta A001, which is the study conducted in China. So I think this study here, the study drug is the Beta A001. The control group is the lapatini and also the capecitabine. Now, so here's their phase 1 paper with published in Cancer Communication. So here they identified the maximum tolerated dose as the 3.6 milligram per kilogram body weight, and then they identified the ORR as the 41.4%. Okay. Now here we compare their results with the Emilia's result as the second line, and also the Labatini and capecitabine results. So we can see that here in this Emilia study, they have ORR for 44% or 31%. But here, in their result, their ORR based on 22 individual sample size, they have about 41%. However, because of the small sample size, right, so they only have a 10 individual receive 3.6 milligram which is their final dose. Now, from there, they have only 30% ORR after deleting this the one individual, which is the unconfirmed. So if you just look at this, the 30%, it looks like they do not have enough evidence to support them going to phase 3. And also you can see the PFS is a bit lower than the other two arms conducted in the Emilia study. So I think from this point of view, there's not enough evidence to support them moving on to phase 3 study, but they move on anyway. So at the end, they have the study got a negative result. So one last thing I want to say is about this breast-09. So I think we are going to discuss this in next week. So this study has the 3 arms, and I think also this is the design of the study. So without further talking too much about this study, I think we want to wait until the next week and discuss this study in detail. And at the end, I want to bring your attention to our course designed by Dr. Ying Yuan and myself. Here's the syllabus of 20 lectures. I think this class cover all the important materials in the clinical research design, specifically in randomized controlled trials. And we cover all the details from all the way from phase 1, phase 2, and all the way to phase 3. So please take a look at this the QR code and if you are interested in this. Okay, and next after this webinar, we at the 10:30 a.m. Beijing time, we are going to have a more discussion, and you're welcome to go into to this webinar and also discussed with us. And I'm going to stop here. Thank you very much. And next, we are going to have a panel discussion. The panel has Dr. Sarah Hurwitz and myself and Dr. Ying Yuan from MD Anderson, and also Dr. Jian Zhang from Fudan University and Shanghai Cancer Center, and also Dr. Chao Li from Cancer Hospital Chinese Academy of Medical Sciences. Let's welcome all the panelists. I think the first question I have for panelists is that, do we have any questions for Dr. Hurwitz?
Yeah, so this is Ying Yuan. I'm a professor in biostatistics at MD Anderson Cancer Center. Yeah, first, thank you, Dr. Hurwitz and Sam for very nice talk. One question I have is, I think for Dr. Hurwitz is, as Sam mentioned, in this trial, quite a bit brain metastasis patient has been enrolled. So why, at the beginning, design the study, brain metastasis, it's not selected as a stratification factor?
Yeah, I think it's a great point, and Dr. Lo just presented some very nice arguments in favor of using brain metastases as a stratification factor. I think when the study was designed, there were other features that were felt to be more important and more prevalent that needed to be included as stratification factors, such as the use of prior pertuzumab, which can indicate a more heavily pretreated patient population, and also as a surrogate for the region of world, right? Because pertuzumab is not available everywhere. And then the presence or absence of visceral metastases. We know that visceral metastases, similar to brain metastases, are very much associated with outcome and length of progression-free survival. As you can see with the PFS and objective response rates, patients with visceral metastases tend to do more poorly, and they also tend to be a higher proportion of the patient population. So I think it's important for that to be balanced. It would have been great to also use baseline brain metastases as the stratification factor, but we know that too many stratification factors can result in too few patients per strata. And so with already having selected the 3 stratification factors, I think it was simply a choice made. And I think, in retrospect, they didn't make a bad choice because only 15% of patients had baseline brain metastases in each arm, and they were balanced. So perhaps the visceral metastases was a surrogate for patients at higher risk of brain metastases and ended up evenly distributing them across the 2 treatment arms. I do think that there are studies ongoing now that are allowing patients with active and progressive brain mets where they will be doing brain mets as a stratification factor, and that will be certainly important if you're expecting a higher proportion of the patient population to have that.
Yeah, thank you. Yeah, I think that makes sense. The other question I have is, T-DXd has striking treatment effect on brain metastasis. So can you give your thoughts about what's the mechanism on that? And do you think, the T-DXd can be used for treating like GBM, which, typically don't really have much HER2 positive patient? What's the mechanism? Why it works so well in this case?
Yeah, I think all of us were really struck by those intracranial responses because the way that we think about these large, bulky antibody drug conjugates, we don't think they can actually pass the blood-brain barrier and get into the central nervous system compartment. However, all the patients, essentially who had brain metastases had undergone, or the vast majority had undergone surgery to the brain or radiation to the brain. And we know that that opens up the blood-brain barrier. There is even data suggesting that simply passing a large, bulky metastatic cell through the blood-brain barrier may provide an opening for drugs to enter that compartment. And if you look at the data, it's actually quite interesting that nearly 34% of patients treated with TDM1 had a complete response in the brain or a partial response in the brain. So even TDM1 was generating some interesting intracranial responses. Now, TDXD was better, but TDXD was also better extracranially than TDM1. So perhaps it's just doing what it normally does. It's got a different and more potent payload. It doesn't rely as much on high levels of HER2 expression. And so perhaps that's why we were seeing such high levels. But I think we're going to need to, going forward, remove our preconceived notions that these molecules can't treat brain metastases. And I'm happy to see now clinical trials that are designed similar to HER2CLIMB, where patients enrolled are allowed who have untreated or progressing brain metastases as being eligible for the study. I think we need to interrogate this question a bit further and not just assume that this is a sanctuary site.
Yeah, thank you.
Dr. Zhang, do you have any questions?
Okay, I think Sarah has a. Hello, can you hear me?
Yes, please go ahead. Yeah.
Okay. Professor Sarah got a good presentation about DB03, and we found that actually this also is a PFS and OS question, because for the second or third line for breast cancer patients, usually the FDA defined as the OS as a co-primary endpoints or as a first co-primary endpoints. So why for this special drug they approved the PFS only as a primary endpoint? Actually, we think that the PFS, according to DB01, should be a positive result. So if we have these results anticipation, why the FDA still consider PFS is okay? Thank you, Dr. Sarah.
Yes, it's, the use of PFS as an endpoint to enable regulatory approval remains very controversial. However, I think that Dr. Lowe made some very important points in his presentation about this, and I would only add that for HER2 positive metastatic breast cancer, we have so many therapies we can treat patients with. Patients are living a very long time. I have a number of patients living over 10 years. And if you looked at Destiny Breast 01, the median prior lines of therapy received by one of the patients on that trial was 27. The range went out to 27 prior lines. The French groups published the ESME real world data from their comprehensive cancer centers this last year, the ESME real world data from 18 comprehensive cancer centers, and showed that the median overall survival for HER2 positive metastatic breast cancer has improved substantially from 2008 out to 2013 or 2014. The median overall survival hasn't even been reached for patients diagnosed in the real world more recently than that time period. So it will take us a very long time to see overall survival differences in a randomized trial. And if the FDA is waiting for overall survival to grant approvals, patients will be not allowed to receive these drugs while waiting for that gold standard endpoint. given the high significance achieved in the PFS with this study, I think we would all be very surprised if overall survival were not demonstrated. But the question then becomes ethical. Do we have to wait the additional 1 to 3 years to see overall survival before the approval is made? And so I think with these considerations, the FDA made a decision to allow it to not be a co-primary endpoint in order to achieve approval, or at least accelerated approval. Indeed, they approved it based on single-arm data, not even a randomized trial. So our patients do have it available in the US.
Okay, it seems that this is also a decision from the patient point of view to get the drug as quickly. Indeed, the same is true in China. It is more and more difficult to make a difference in patients' OS because there are so many clinical trials to participate in, especially for the HER2-positive patients. I got it. Thank
you. Dr. Li, yes, please, go ahead.
Thank you, Professor Luo and Professor Hurwitz. Thank you for your presentation. I'm quite interested in the adverse events of this drug. As for the results of the DB03, actually the adverse events rates was actually higher. I think higher in the TDXD arm compared to the TDM1 arm, but it seems patients in the TDXD arm have a longer treatment. Much longer, actually. So how do we evaluate the adverse events rates between these arms, between these two drugs? Can we say it's comparable, or maybe this adverse events was cumulative, so I want to ask, how do we evaluate the adverse events?
Yeah, it's a really good question. And as you mentioned, patients in the TDXD arm, because their progression-free survival was so much longer, they were exposed to the drug for a much greater period of time than TDM1. And that's why an analysis was performed and presented at San Antonio called the exposure-adjusted incidence rate, which I had not been familiar with, but I have seen subsequently a lot of literature looking at this as a way to account for the imbalance in duration of treatment. And when you look at the rates of treatment emergent adverse events for TDXD versus TDM1, taking into account the length of time patients were treated, you're right. Actually, it seems more balanced and equivalent between TDXD and TDM1 when you look at the rates. And in some cases, even a little bit favors TDXD. So I think that we have to keep that in mind for any study. If you look at the HER2 CLIMB trial, a totally different study, tucatinib, capecitabine, and trastuzumab, the blinded study, and they saw much higher rates of diarrhea in the tucatinib arm. And you have to keep in account patients were being treated with tucatinib and capecitabine, which causes a lot more diarrhea for a longer period of time. So it's not unique to this study. When you see patients treated for a longer period of time, you're going to accumulate more adverse effects. But I do think that there are key differences between the two treatments that clinicians need to be aware of. I'm sure you all have this in your own practices. We have to warn our patients about the risk of neutropenia with TDXD, which is different from TDM1. We don't see as much thrombocytopenia, but we do have patients at higher risk of infection and neutropenia. I'm seeing more hair loss, maybe because patients are on it longer. So there are differences that do distinguish the two agents from one another. But I think your point regarding duration of treatment is a really important one for us to keep in mind as we interpret these data.
Yeah, thank you. So because previously for other studies, we seldom consider the duration, the adverse events correlated with duration. So for this study, I think, because in our center, we also treat some patients and over half a year or even longer. over 30 cycles. So for those patients, they actually undergo more adverse events. Actually, yeah. Okay,
yeah, absolutely. Yeah, it's a really good point to keep in mind as we look at the data.
Mm-hmm.
Now, Dr. Hurwitz, I have a question also related to AE. So now we talk about this ILD AE. So I think one method they use is the exclusion criteria, right? So besides that, do you think they have other way to manage those ILD as AE?
Yeah, so this protocol had a couple of features that I think protected patients more from developing grade 4 and 5 ILD. There was an independent adjudication panel of experts in lung disease that evaluated all cases of ILD independently. And so that there was this special oversight just for that side effect. As you mentioned, there was an exclusion criteria that ruled out any patients who had a history of ILD in the past that required steroids. Or any suspicious ILD that couldn't be ruled out by imaging at entry. Moreover, in terms of management of ILD, if patients even developed interstitial infiltrates or ground glass opacities on scan, but were completely asymptomatic with a normal O2 saturation, treatment had to be held. It was mandatory. So that's grade 1 ILD. You stop TDXD. That's different from any other drug where we see pneumonitis or ILD. Usually you just monitor a patient with grade 1 ILD, but in this case, we stopped therapy. We saw the patients again within a week to recheck their O2 sat. We considered referring them to a pulmonologist. We repeated imaging at 4 weeks. If it had resolved, then they could resume TDXD. But if it took longer than 4 weeks to resolve, then we had to reduce the dose of TDXD by 1 dose level. And for anything grade 2 or greater, TDXD had to be permanently discontinued. The protocol specified that high-res CT scans had to be done, that pulmonologists and infectious disease specialists should see the patient, bronchoscopy and BAL. So it was a very detailed protocol in terms of workup and management. And I think that's what helped us achieve the low levels of ILD and no grade 4 or 5 events.
Thank you. Thank you for the detailed insight. Yeah. Dr. Zhang or Dr. Li, any additional question?
Actually, the TDXD has a good response in the brain metastasis. This kind of patients, especially for the study, I think the Tuxedo clinical trials has also recruited some patients very high, almost 80% of the patients have the response, and are also maybe not even very clearly. The DB12 is a study to MBC with or without the baseline metastasis to compare or TDXD and TDM1. So why this is so much difference between the TDM1 and TXTD, and for almost they are both ADC for the brain metastasis. And do you think we can use in the future to use a DXTD as an adjuvant setting or consolidation agitation to prevent the brain metastasis? Thank you.
Yeah, the activity of TDXD in brain metastases is really quite interesting. Again, it was an exploratory analysis of this study, but it was quite interesting. I agree. And I agree the Tuxedo data that were presented at ESMO were really interesting. Numbers were very, very small. I think only 6 patients, but to see the objective response rate in the brain for patients with active brain metastases at that level was very impressive. And then at San Antonio, the DEBRA study was presented from the Spanish group looking at an observational or I believe it was a prospective single institution study, again showing, I think, above 60% intracranial objective response rate in patients who had brain metastases. And they had patients with HER2 positive breast cancer and some with HER2 low breast cancer, but they presented the HER2 positive data at San Antonio. And so, as you mentioned, the Destiny Breast study that's ongoing now, DB12, is going to interrogate this question further and give us more insights. I think the reason maybe we're seeing a greater activity in the brain with TDXD versus TDM1 is that maybe TDXD is just a better drug. It doesn't require high levels of HER2 expression the way that TDM1 absolutely does. It has this bystander effect. The payload is a cytotoxic agent that breast cancer is not typically treated with. So resistance to this type of inhibitor, topoisomerase inhibitor, is less common because patients haven't been previously exposed. So it may just be a better drug, which is why we may be seeing better outcomes in the brain. The drug is being evaluated in the curative setting, or plans are, as I understand it, to evaluate TDXD in high-risk patients. And I know that they'll be following to see whether TDXD helps prevent brain metastases in high-risk patients in the curative setting. This is in the context of a number of studies ongoing looking at this, including studies with tucatinib, to try and evaluate whether brain mets can be prevented. A very important question.
Thank you for a nice comment. And another question, maybe you see that the poster presented in San Antonio this year, last year, showed that the key subgroup analysis includes the pre-specified subgroup, such as hormone receptor status, prior atezolizumab treatment, visceral disease, and also include other 2 key subgroups, prior lines of therapy, patient with metastasis. So why? I think the patient number is limited, so we don't. We cannot choose all of the subgroup analysis that were specified. So what's your point of view to before the clinical trials that is carried, why you choose these 3 as the first 3 specified subgroup analysis not include other key factors? Thank you.
Yeah, so I think we, as a steering committee and the company sponsor, have lots of discussions about what's going to be important to look at. We bring with it our expertise as clinicians treating patients. We bring with it our experience in clinical trials and our understanding of what tend to be subgroups that have different prognostic outcomes, or maybe have different predictive capacity for benefit from a certain therapy, which is why I think looking at subgroups based on HER2 expression levels is going to be very important from these studies. That will be forthcoming in the future. And so I think we do our best to figure out subgroups. And, I'm sure you've noticed as you review the literature that a lot of times you'll see a study report its primary paper and they've reported on 6 subgroups in a forest plot. And then 2 years later, there will be a new publication looking at certain molecular subgroups or other subgroups that have come up because another group or another study has identified a key subgroup that we should have looked at. So you go back and you do retrospective analyses. So I think we do our best to specify prospectively which subgroups are important to look at, but that doesn't mean that that's all we'll be looking at. We'll certainly, we have the database available, and we'll be able to go back and look at a lot of these questions as they come up.
Mm-hmm. Yeah.
Yes. Thank you.
Yeah. Wait, Dr. Zhang has asked I just asked actually the same question, but so how will the subgroup? So if we choose the right subgroup, maybe it will have more. It will have the positive effect for our subgroup analysis in the outcome, or is there any relationship between the stratification factor and the ultimate the subgroup analysis? Is there any relationship?
So are you asking if there's a relationship between the stratification factor and what we see in our subgroup analysis?
Yeah.
I mean, I think indirectly, perhaps, maybe Dr. Lowe would be a better one to answer that question, like how they correlate. But I think you choose stratification factors based on those features that may impact your readout. And because you want them to be balanced so that you're not confounding your result based on an imbalance in something that may be prognostically important or may relate to how well the drug works. And so I think it's then important to look at the outcomes based on those subgroups. And those are sort of pre-specified subgroups you're going to look at to see how they do overall. And then as an exploratory evaluation, you can also look at subgroups that you didn't stratify for. But I may not be expressing this as eloquently as Dr. Lowe may be able to.
Yeah, I think you cover all the points. Now, I want to turn the topic a little bit. So I want to ask about the sample size. So, and also about how to identify the optimum dose. So, as I mentioned a little bit before, so in phase 1, they use more than 100 patients to find the dose. And then in phase 2, they use another 100-some patients to find the dose, right? So is it really necessary, or what's the best way to find the optimum dose? I want to ask both Dr. Hurwitz and Dr. Yuan about this.
Yeah, from my point of view, it was a lot of patients, and I wasn't necessarily a part of that decision process. However, I do think that there was a lot of awareness of this interstitial lung disease issue. And so I think that the leaders who are making the decision regarding how many patients to look at in the smaller phase studies wanted to make sure that they were maximizing efficacy, because efficacy did seem to have a dose relationship, but minimize the risk to patients. So they wanted to sort of augment and explore that in a larger setting, rather than getting to a really large phase 3 trial and then seeing 3 to 4% of your patients die from a side effect because you chose the wrong dose. So I think they knew there was this potential life-threatening side effect that they really needed to, they couldn't just go on very small numbers. But Dr. Yuan, maybe you have further insights to add.
Yeah, so probably I can give a little bit comment first for I think it's at the subgroup analysis, and then I can go to this point in terms of optimization dose. I think for subgroup analysis, typically for such a trial, most of it's exploratory nature, and in that sense, actually, in the protocol, you can specify a number of subgroup analysis you want to do. And I think that the really make difference is, do you trying to make a confirmative conclusion based on certain subgroup analysis? So if that's the case, and in the protocol, you have to adjust alpha to do that. Because in that case, I think we should be more careful, pick, one or two subgroup analysis. I think that's pretty common in PD-L1, target agent, those immunotherapy. They look at the all-comer and then they look at the PD-L1 positive patient. And in that case, those subgroup is more kind of, we can call a predictive biomarker. And they tend to be make difference in terms of treatment effect. I think in the this O3 trial, if you look at the brain metastasis and also subgroup, they tend to be kind of prognostic factor. If you look at it, the hazard ratio are pretty similar in those two group. And that means the patient may have different survival or PFS. But in terms of treatment benefit, I think they are very similar, right? One of it's like 0.3, the other 0.28. And in this case, I think, it's fine. And I think that's one point that I want to make. I think the key is, do you want to make confirmative decision based on the subgroup or not? And from FDA perspective, that's also the same thing. That's why you see a lot of trial. If they specify ITT population and also subgroup population, they have to do alpha adjustment. So that's for that question. And I think for dose optimization, actually, I think, this PDXD program, I think has done a pretty good job, I think, in terms of that. And you can see after the phase 1 dose funding, they look at the 3 doses as Dr. Law showed. And then further, they pick another 2 doses to treat more patients. Eventually, they pick another dose to do the phase 2. And I think if you follow FDA and many trial, even though recently FDA put a lot of emphasis on this point. And I think probably a couple months ago, I think they published a New England Journal of Medicine paper, a specific talk about this. And a lot of trial, you get feedback from FDA. They ask you optimize those. And also FDA, I think recently also launched they call the Optimus project. The whole purpose is I think they draft a guidance trying to give more guideline on the dose optimization for a targeted agent. And I think in this case, I think this this trial actually has done a pretty good job. And the question is, can we do better? And I think certainly we can, in the sense, I guess, okay, this trial, they have multiple stage for optimization. I think it's mostly because at that time, when they design the trial, they don't really, think that far. And once they see pretty good signal, they plan next one. That's why it's results in pretty big sample size when they doing such optimization. And of course, I think this trial, initiated, several years ago. I think at that time it's pretty good, well-designed trial. But I think looking forward, I think we can think those point a priori and design the trial in a way we streamline the whole optimization process. So, for example, in this trial, I think they look at the 3 doses, each treat 20 patients, and then they, based on the PK, pick another 2 doses. And I think, if I remember correctly, Dr. Lowe's slides is they treat another 30 patients on the 2 selected doses, and then to pick the last one, treat another 100 patients, right? And I think we can take adaptive approach. So, for example, you can look at the data, interim data more frequently. And because at that stage, it's kind of more exploratory process for optimization. So you won't have the issue, you spend too much alpha because you look too many times. And our goal is, you can make more quickly adaptive decision. If one dose, it's not more effective, but have more AE, you can drop that dose. And you can immediately put more patient on the more promising dose. And, eventually you can quickly pick the optimal one and do cohort expansion on that dose. So I think that's a more streamlined approach. And I think hopefully we'll see more such approach, especially, FDA put a lot of emphasis on this aspect. So that's my thought on this.
And also, we have 4 questions in the Q&A section. Dr. Hurwitz, could you answer some of those? You can pick any question you want to answer first.
Sure. I think one very good question is how often to follow CT scans to monitor for interstitial lung disease in patients receiving TDXD in clinical practice. And I think that's a very good question because on the clinical trials, we were monitoring patients every 6 weeks with scans to look for progression or response to therapy. And in clinical practice, we usually are not scanning patients quite so frequently. A patient who's doing well, I'll scan every 12 weeks or 15 weeks, and patients who've been stable for over a year or two, I'll pull back to every 6 months. But with a drug that can cause ILD like this, that can be life-threatening, I think it's important to stick with the way that the clinical trial was run until we understand more about ILD, especially in the era where we have COVID infections that complicate our interpretation of somebody who develops a cough or shortness of breath. So at least for lung imaging, I think doing at least around 6 weeks or 8 weeks to look at the lungs, just to make sure that there are no ground glass opacities developing. It may seem like overkill, but we do have other effective drugs for HER2-positive breast cancer, and we want to make sure that we're not missing a situation where we could nip it in the bud and stop early. Do you want me to take another one, do you want to pass it to
please, in the interest of time, yes.
Okay. Another question was, I think we already answered the mechanism of action of TDXD and the blood-brain barrier. And then the level of HER2 expression wasn't stratified in this study. Patients who had 1+ or 2+ expression were, of course, allowed as long as they were FISH positive. And that will be presented at a later time, looking at HER2 expression levels and outcomes. But as was pointed out by the person who asked the question, Dr. Fang, this TDXD does appear to be effective regardless of HER2 expression level. We've seen responses in HER2 low breast cancer. There's a large clinical trial, Destiny Breast 04, I think, ongoing now, looking at TDXD in HER2 low expressing non-amplified breast cancer. And so while we didn't stratify for it in this study, it would have been too hard to stratify. We would have had to do central analysis for HER2 expression, given the interlab variability for 1+ and 2+. But this will be looked at in the future, and I think is being looked at in other clinical trials as well. I think those were the main important questions. Just intracranial remission, non-CR, non-PD, I think are patients who didn't qualify as having stable disease lasting at least 6 months. And I think that's where the non-CR, non-PD numbers come from. I would actually have to confirm that internally, but I believe that's what the non-CR, non-PD means.
Thank you very much. Yeah. I think in the interest of time, let me ask one question. So assuming this drug will be approved, now, is there anything we can do in the real world study to study more about this drug?
Well, I think that real world studies are going to be important. It's already available in some countries. It's available in the United States for third line setting and beyond, and many of us are using it in second line setting now. Our NCCN guidelines and ESMO guidelines are now endorsing its use in the second line setting. And so I think real world studies are going to be really important for us to know in a real world setting how the rates of ILD do. Because if clinicians are not used to following scans and holding therapy and managing ILD the way it was strictly managed on this protocol, we have to pay attention in the real world setting if that number goes up. And I think it's going to be really important to use those studies as an opportunity to teach us where education is going to be important and where there are gaps in knowledge, so that clinicians can be prompted to manage ILD and look for ILD more. That's one area where I think real world studies are going to be very, very important. Also to sort of confirm the efficacy that we're seeing, but with respect to toxicity, that's going to be key.
Any other comments about this topic? About the real world study, what we can study? Anybody? I think one thing I want to see in the real world study is that the optimum dose for each individual. So I know that currently we have this one size fit all, right? So, but however, for some individual, 5.4 may not be the optimum one, right? So it could be lower. Lower dose could be better in terms of management of AE. So I think this is also a pretty hot topic now to identify the optimum dosing, individualized dosing.
I agree completely. Yeah, I think that's going to be really important. And patients do often have dose reductions. So looking at that in greater detail and associating that with efficacy and outcome will be important.
Okay, at the end, I want to spend maybe 20 seconds to sum up what we have found in this study. So I think the most important thing, there are many different points that we need to mention. So one is that the early phase study really matters in terms of helping you design the later phase study, and finding optimum dose is critically important. And then select the right endpoint and using the right strategy to control alpha if necessary, and also have a sufficient power in your design, and also good management of AE. And also using the good strategy. You know, if you are not sure how good your medication is, you may also want to start from the later phase when you don't have that much competition. That's my takeaway. Dr. Hurwitz or somebody else, any other comment about this?
No, I think you summarized it really well, and I think it's very exciting data, but I think you highlighted the areas where we really need to see more data. I think we're all really looking forward to seeing overall survival and seeing more data relating to its efficacy in the brain.
Yeah, so I think this is a huge success if we look at the, how separated those two PFS and OS. It's really striking. So I'm looking forward. This drug can be applied or investigated in other indications like ovarian cancer. They also have a lot of HER2 positive patients. That's looking forward to those study and the results.
Thank you very much. I think we have a few more housekeeping issues. Can we go to the next page? Yes, and I want to mention that this webinar is hosted by eChinaHealth News. Please pay attention to their news and also the activity they organized. Next page, please. And then there's a healthcare startup roadshow coming up. Please also pay attention to the time. And as I mentioned a little bit earlier, so we have next week we are going to have a similar webinar to discuss the breast 09. So please tune in. Yeah, so thank you very much for your attention, and thank you, Dr. Hervis, for your excellent presentation and also all your insight. Thank you very much, and also thank Dr. Yuan, Dr. Zhang, and Dr. Li for all the questions and answers, and also thank the audience for tuning in today and also for your question. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you.
Bye-bye.
Daiichi Sankyo,